I'm sorry about that. Okay, well, good morning, everyone, and welcome to today's talk. I just wanted to talk today about skin infections in children, and today we're going to cover some common infections, rashes in children that we can see anywhere in the world, and also some less common conditions that more commonly occur in children who live in tropical environments, and there's good reasons for that. First of all, we need to have an understanding of terminology, and these are some words that are very useful in describing different sorts of skin rashes. And I think you need to have a good understanding of these terms, because you can, by the combination of these terms, you can really describe almost any sort of rash. Now, first of all, erythema, that's just redness. Papula means that there's you can feel the rash, that there's a rash that extends above the surface of the skin. Macula just simply means that the color of the skin lesion is different to the surrounding skin. It can be a dark macular rash, or it can be a light macular rash, or it can be a red macular rash. The point is the color is different to the surrounding skin. Purpuric actually denotes a color. It indicates, like erythema, it denotes that it's purple in color. Suppuration means that there's some sort of pus formation within the skin. Vesicular means it's fluid filled, and usually a vesicular rash is filled with clear fluid. That's different to pustular, which is more like suppuration, filled with pus. Hypopigmented patches I'm going to be discussing a bit today, because they're a common skin problem that often doesn't come to the attention of doctors, but they're seen fairly commonly, especially in tropical environments. Hypopigmented, that means the skin pigment over the rash is lighter than the rest of the skin. And there's three different causes of hypopigmented patches within the skin. I'm going to be talking a bit about granulomas, which are a bit like suppuration, but they're not acute inflammation and suppuration, but they're more chronic inflammation. I'm going to be talking about chronically inflamed granulomas. Many skin ulcers develop from a granuloma, and I'm going to be talking a bit about ulceration and the causes of that. We'll talk a bit about cervical adenitis, because that's a common skin infection, or skin and soft tissue infection in children. And then, so that's terminology. If you can master that terminology and understand what all those terms mean and how to use them and how to combine them, then you go a long way to be able to describe common pediatric rashes. Then you need to ask the question, is it a localized infection, or is the child systemically unwell? Many rashes are just localized infection and the child's otherwise well, and some rashes relate to a generalized systemic illness in a child. And from that understanding, that can help you with the diagnosis. The question about inflammation, which we'll come back, I alluded to before, but we'll come back to, is it an acute erythematous inflammatory response, or is it a chronic granulomatous inflammatory response? And we'll give some examples of that so you can understand. So these are some of the infections I want to cover today. There are some talks where I've spoken about common viral infections, common viral skin exanthems, but I'm going to cover them again today briefly, and I'll talk about the different types. Viruses are really common, and often we have an understanding of acute fever and rash, but the differential diagnosis of acute fever and rash is quite broad and contains many viruses. It also contains two bacterial infections, and the two commonest bacterial skin infections are Staphylococci and Streptococci. And you'll see that staph particularly comes up in many of the different skin rashes that we see as a differential diagnosis. I'm going to be talking about a bit about fungal infections, especially tinea versicolor, which is a fungus that causes hypopigmented patches in the skin. And I'll speak a bit about atypical Mycobacterium, so not Mycobacterium tuberculosis, but atypical Mycobacterium that causes some skin rashes. Mycobacterium ulcerans, which causes the Buruli ulcer. Mycobacterium marinum, which causes it's often called fish tank granuloma, or granuloma related to salt water in tropical environments. And then the maize complex, Mycobacterium avium intracellulare, which is a atypical Mycobacterium that causes cervical adenitis and a sort of cold abscess in the neck. And sometimes we think all of these things, cervical adenitis related to the maize complex, is Mycobacterium tuberculosis, but it might actually be a different form of TB. I'll talk a bit about parasitic infections, particularly only two we'll touch on briefly. The cutaneous larva migrans, which is a nematode worm, which causes a characteristic rash on the skin, and then scabies, which of course is probably the most common parasitic and one of the most common skin rashes we see in children. I'll briefly mention vitiligo because that's part of the differential diagnosis of hypopigmented rashes, and we may touch on zinc deficiency as something else that causes skin rashes that we often mistake or may mistake for some other diseases like staph infection. It falls into that differential diagnosis. So acute fever and rash, I'm going to talk about the viruses that cause acute fever and rash, and these are the two most, I guess, important viruses that cause acute fever and rash. On the left is a child with measles. On the right is a child who's got rubella. And they're almost indistinguishable, but not quite. And measles is a coarser erythematous maculopapular rash, and rubella is typically a very fine erythematous maculopapular rash. You can distinguish measles because it causes coryza, cough, conjunctivitis, sometimes Koplik spots, a high fever, and rubella doesn't usually have conjunctivitis. It typically doesn't have cough. It is somewhat different. So you can make that distinction clinically, but sometimes it's only identifiable with testing. Historically, there's been 6 erythematous rashes of childhood, and they're not all viruses, and they were described in sequence, and some of them were named as the first rash or the second rash, and measles was the first rash described. In fact, thousands of years ago, measles was described first, and then came scarlet fever, which was very common for hundreds of years. Scarlet fever due to Streptococcus pyogenes or group A Streptococcus. And then came German measles or rubella, which I showed you a picture of before. And then came staph scalded skin syndrome or staph toxin mediated disease. I'll talk a bit about that, described in the 1800s and 1900s. And there's a virus infection called fifth disease, or it was called fifth disease, simply because it was the 5th type of erythematous infection, red rash to be described, and that's erythema infectiosum. And sometimes it's called slap cheek rash, and it's due to parvovirus B19. It's only the fact that it's due to parvovirus B19 has only been worked out in recent decades, but always before it was called fifth disease, and it has a characteristic erythematous rash on the cheeks particularly, and a finer rash on the body, but very much bright red cheeks these children get with a fever. The 6th red rash to be described is called roseola, and that's usually due to HHV6, which is human herpes virus 6. Sometimes it's due to HHV7, but usually HHV6. And another name for it was called exanthem subitum. Exanthem being a red rash, and subitum is Latin for quick. And that describes roseola very well, because there's usually a sudden onset of a very high fever, and sometimes it can be above 40, and then followed by the rapid onset of a rash when the fever goes down. So when the fever subsides, you think the child's getting better, and then the rash comes out. And it's usually a widespread erythematous maculopapular rash. It's usually not as coarse or as confluent as measles or rubella. It's usually a bit sparse, but it's always preceded by a very high fever. And that's usually it's usually a fairly benign illness in children, but some children can get very sick with roseola. Usually with fifth disease, slap cheek rash, they don't get very sick unless with this parvovirus B19, unless they have some underlying condition, and especially the hemoglobinopathies like thalassemia or sickle cell disease. Those children can go into an aplastic crisis if they get erythema infectiosum or fifth disease, the slap cheek rash. They can get severe aplastic anemia, and it can happen to other children that don't have hemoglobinopathy as well. But that's one of the features. Usually a benign disease. Sometimes it's a bit more serious. With roseola, it's usually a benign disease, just the fever comes and goes, and sometimes it's a bit more serious. Almost all of us have had HHV6 in the past. Most people have antibodies to HHV6, which tells you they've been exposed before. Then the last infection I wanted to touch on, I'll show some pictures of all of these, is hand, foot and mouth disease. And that's due to enterovirus 71, which is it produces a rash that's very tender and painful, tiny little not pustules, but blisters on the hands, feet, and within the mouth, small ulcers within the mouth. Again, usually that's quite a benign disease, but sometimes in some populations it can cause encephalitis or other problems like myocarditis. I'll explain that as we go. This is the rash of scarlet fever. There's other talks where I've talked about measles and rubella, so I just wanted to touch on scarlet fever. It's a red rash that looks a bit like measles. The differences are, if you look in the flexures, like around the skin of the neck or the skin of the armpits or in the groin, the rash is much, much more red. And the rash starts about 24 hours after a fever. It's brighter red in the skin creases. There's sometimes these things called pustule lines. That usually doesn't happen immediately, but pustule lines is where you've got a very marked inflammation in the skin creases, and that leads to some bleeding underneath the skin because the vessels are quite friable. It's almost like a vasculitic rash in the flexures of the skin, and you see straight red lines. They're called pustule lines, which are characteristic of scarlet fever. It's papular, which you can see the picture on the left indicating it's papular. You can feel it. It's often said to be like sandpaper. And sometimes these children have a strawberry red tongue, and they often have what's called perioral sparing. That is, the rash isn't around their mouth. The rash is, there's normal coloured skin around the mouth. The rash doesn't occur around there. Many of these children have systemic features, sometimes not too much. They just have a rash and a fever, but sometimes they have a sore throat or swollen glands in their neck if they've got a streptococcal infection in the throat. And sometimes they have other systemic features, headache and nausea, abdominal pain, generalized aches and pains. The rash starts to resolve after 6 days, and then you get peeling of the skin, especially in the areas where the rash was most prominent, like in the skin flexures, in the armpits, in the neck, in the groin, and the fingers and toes particularly. So this peeling rash sometimes is mistaken for staph scalded skin syndrome, but it's just part of the recovery of scarlet fever. Scarlet fever is, I think, it used to be very common in the 1950s and 60s, and then it became much less common, and now it's becoming more common again. So look out, there'll be children who have scarlet fever from a group A strep infection. It's not streptococcus in the skin, it's a rash, immunological reaction to scarlet fever to group A streptococcus, in a similar way that you can get acute rheumatic fever as a immunological reaction to group A streptococcus, or you can get post-streptococcal glomerulonephritis. So those three syndromes, scarlet fever, post-strep glomerulonephritis, and rheumatic fever, are all consequences of group A streptococcus. Staph scalded skin syndrome was described around about 130 years ago, and it is characterized a bit like scarlet fever, with a fever and a systemic illness and redness and tenderness of the skin. It's not as I would say sparse, or it's much more confluent, where you get the entire skin that is affected is red. Doesn't have quite the same appearance of scarlet fever or measles or rubella. It's more a generalized bright redness of the skin. The skin is also very tender, and it usually breaks out into fluid-filled blisters that can rupture easily. And then you get peeling of the skin after the blisters rupture, and that has risen. What's arisen from that is this sign called Nikolsky sign, which is where the epidermis sloughs off. When you just gently touch the epidermis and slide your hand across the skin, then the epidermis peels off in areas that are very inflamed. It typically occurs in children who are young, so children aged 2 to 3 is the most common age group that gets staph scalded skin syndrome, but many children can get staph toxin mediated disease that looks very similar to this widespread red rash. Now, staph scalded skin syndrome is produced by not the bacteria itself being in the skin. It's not cellulitis. There's a toxin produced by some form of staphylococci that breaks down the protein between the dermis and the epidermis and causes inflammation and the epidermis to peel off. Sometimes children have more systemic features. It's very rare that you'll find staphylococci in the bloodstream of children with staph scalded skin syndrome, because it's a toxin mediated disease. So they will have staph somewhere. It might be a small pustule or an abscess or a burn, and or a cut where staph gets in. Even scabies that can lead to staph scalded skin syndrome if the scabies get secondarily infected. But it's not like skin cellulitis where you have staph in the skin. It's a reaction to the toxin that's produced by Staph aureus. Sometimes staph can cause ulceration and direct infection of the skin. I won't go through this too much, but this is a child who had severe staph pneumonia. You can see has got an empyema and has skin ulceration. And that's a direct infection of the skin, as opposed to staph scalded skin syndrome, which is caused by a toxin-mediated disease. I mentioned before enterovirus 71 as the seventh, if you like, exanthem of childhood, and this has been described for several decades, but it causes, most commonly, it's a benign condition. It causes these blisters on the feet or on the hands, in the mouth, ulcers in the mouth, hand, foot, and mouth disease. It's actually quite common. It's generally quite self-limiting. The children have fever and they have these blisters, and then it goes away. But there are some populations that are more susceptible to more serious infections, and there's especially among children in Asia, in China, in Vietnam, in Malaysia, Indonesia, there is a risk of getting serious neurological abnormalities, especially an encephalitis, a brainstem encephalitis, and also cardiac and pulmonary complications, pulmonary edema, myocarditis. They're surprisingly much more common among children in Asia. I don't think we know what contribution enterovirus 71 makes to encephalitis in Papua New Guinea or in Pacific Island countries, but it might make some contribution, and there might be some children that have an enterovirus 71 encephalitis. And I think the key is that at least all the children I've seen with the encephalitis also have the skin pustules, and so it's worth looking at the child's feet and in the mouth and the hands to see if they've got those features. I wanted to move on from erythematous rashes to hypopigmented patches. And remember we said that this is very common. You'll have seen lots of children, I think children and adolescents particularly, with hypopigmented patches. And it can be due to conditions that are quite benign and conditions that are quite serious. And I just want to highlight three causes of hypopigmented patches. There are some more, but particularly these three. The first one is tinea versicolor, which is probably the most common cause of hypopigmented patches that we see, and that's a fungal infection. It's like a tinea skin infection. The second one is leprosy, and you can make the distinction between, even though it can look the same, the hypopigmented patches of leprosy can look a bit the same. You can make a distinction between tinea versicolor and the hypopigmented patches of leprosy just by clinical features, and I'll explain how that's done. And then the last one is vitiligo, which is an autoimmune condition where there are hypopigmented patches because of autoantibodies to skin pigments. So it's sometimes challenging to make the distinction, but tinea versicolor is the most common. This is tinea versicolor. As I said, you've almost certainly seen it. The skin appears lighter or darker or redder than the surrounding skin. Sometimes it's light patches. Usually it's light patches. Sometimes it's darker patches or redder patches. And this is a fungal infection from the fungus tinea versicolor or pityriasis versicolor. You sometimes hear it called that, and it's so common that we often think of it as being normal, and so there are many children that have it. It's actually usually it's asymptomatic. Sometimes it can be itchy, but usually asymptomatic. And there's a number of things you can do for it, for tinea versicolor or the related fungal infection, malassezia, which is another fungal infection that causes hypopigmented patches. You can use an azole like ketoconazole or fluconazole. If the patches are quite extensive, you can use some antifungal cream, but Deborah, would you mind muting your screen, your microphone? Thanks. Thank you. Sometimes even after you've treated the fungal infection, the hypopigmentation persists. Usually it resolves over a long time, but often it persists. So two fungal infections that can cause hypopigmented patches. The difference between superficial fungal infections and the hypopigmentation of leprosy is a few things. Firstly, children who have leprosy, it's not just a hypopigmentation. Usually there's, first of all, often weeks or months before, there's a loss of sensation of that patch of skin. Now, if a child's too young to explain that, then they might not be able to indicate that. But if they're old enough, they'll say, first of all, they'll say that there's been a altered sensation of the skin. And then there's the hypopigmented patch occurs some months or even years later. And sometimes after the hypopigmentation, the patch of skin becomes quite swollen and red. And that then progresses to quite thickened plaques. So instead of it just being flat on the skin surface and hypopigmented, then it's raised and there's a hypopigmented plaque, which is a raised area of the skin. And sometimes there's nodules or nerves that are evident. So you can make the distinction usually between leprosy and tinea versicolor or other benign fungal infections just based on the clinical features. Sometimes there's also multi-system involvement with leprosy, and that's usually due to an inflammatory response, a neutrophil-based inflammatory response to leprosy. It's not usually that the Mycobacterium leprae is actually in the skin where you get the erythema nodosum. This picture shows this is also leprosy in a child who had erythema nodosum. Now that can occur with Mycobacterium tuberculosis, or it can occur with Mycobacterium leprae, and it's an immunological reaction to the bacteria. But you can get immunological reactions in other parts of the body as well. In the eyes, you can get immune-mediated reactions in the testes. Some children who have leprosy can get immune orchitis or inflammation in the liver and in the kidneys and in the bones and joints. And usually this is a amyloid protein that's probably produced by neutrophils that get stimulated by immune reaction. Amyloid protein gets deposited in these organs and can cause amyloidosis of those organs. So there's direct effects of direct rashes that are caused by Mycobacterium leprae, and then there are immune-related reactions to it. I wanted to touch on granulomas now. We've talked about erythemas, we've talked about hypopigmented patches, and now I want to talk about granulomas and what sometimes follows that, which are ulcers. Now, granulomas are areas of chronic inflammation. We've talked mostly about acute inflammation, acute suppuration, acute blisters, acute erythema, but granulomas are a small area of chronic inflammation, and usually it's due to macrophages and T cells, and it's usually the inflammation has a beneficial effect because it isolates a foreign antigen, which might exist in the skin or the subcutaneous tissue, and there's an inflammation to isolate that antigen and stop it spreading more widely. Granulomas can be caseating or they can be non-caseating. It's like pus-forming or not pus-forming. And the caseating ones are Mycobacterium causes caseating granulomas, as we all know. Staph aureus does so, as does Aspergillus, a fungal infection. And the purpose of the inflammation is to isolate those bacteria or fungus to a certain location and stop it spreading more systemically. Or they can be non-caseating, and certainly with a foreign body, you can get a granuloma over time, and that's because of infection and because of inflammation. But the body is always trying to isolate a foreign antigen and stop it becoming systemic and causing systemic illness. A BCG scar is a form of granuloma. It's an inflammation, a T cell macrophage inflammation that is a response to the BCG vaccine. There's some completely immune granulomas, which one's called granuloma annulare, which is what this child had, granuloma annulare. It's sometimes not due to an infection, sometimes it's due to just an immune inflammatory response. I wanted to talk about a couple of granulomas, and particularly this one. And Mycobacterium ulcerans is probably more common than what we think, and you'll see the characteristic features are that it is painless. Many granulomas are painless. If they're suppurative, like staph or foreign bodies, then they're usually painful, but other types of granulomas are often painless, and they have, particularly they start off with a nodule, and that nodule and plaque becomes quite edematous and raised, and then it ulcerates in the middle, and then you get what is referred to as undermined edges. So if you look around the edges of the ulcer, it looks like it's undermined, and you could almost see into the soft tissues deep to the skin. In children, the lower limbs are most affected because the Mycobacterium typically affects the feet and the legs in young children who may get an infection from running around without shoes on in wet, moist environments, dirty environments. It's typically how Mycobacterium ulcerans is acquired. There is some relationship between Mycobacterium ulcerans and some a secondary host. So typically, some sort of possum or some other rodent-like animal is the secondary host, and children typically get infected by contact with the host species that are infected with the Mycobacterium ulcerans. You can tell on if you do a biopsy of such a ulcerated lesion, you can see the Mycobacterium in it. So remember, acid-fast bacilli, Mycobacterium ulcerans. You can see it on histopathological sample, like in this slide here, or you can grow it just like you can grow Mycobacterium tuberculosis on Lowenstein Jensen media, the type of agar, but it takes a long time. Just like TB takes 6 to 8 weeks to grow, then Mycobacterium ulcerans takes even longer, sort of 8 to 12 weeks to grow. There are now PCR tests for Mycobacterium ulcerans, but if you see an ulcer that looks like that, a necrotic granulomatous ulcer, and you do a biopsy or even a swab that has acid-fast bacilli, and it's probably a Buruli ulcer. The treatment for a Buruli ulcer is 8 weeks of antibiotics, and typically combination antibiotics, so rifampicin, clarithromycin, and a fluoroquinolone like ciprofloxacin or moxifloxacin, norfloxacin, but usually it has to be a combination of 3 different types of antibiotics. Rifampicin, which we know treats mycobacterial infection, clarithromycin, which is sometimes used for MDR, TB, and fluoroquinolones, which so a combination of those 3 antibiotics for 6 weeks usually treats it. Rarely do they. Sometimes ulcers need resection and a skin graft, but typically antibiotics will clear it up. Another type of granuloma, but also a mycobacterial granuloma, I wanted to briefly touch on is this one called Mycobacterium marinum. This is a waterborne mycobacterium, and where there's coral reefs, where there's a high density of fish and warm salty waters, so in especially in tropical environments, the Mycobacterium marinum can exist, and especially when you've got either coral grazes or pre-existing cuts on your skin, then Mycobacterium marinum can invade and cause this granuloma. It's a very painful granuloma, and it's usually at the site of a minor scratch or a minor injury. It's sometimes considered to be a bit violet, like it's violet or erythematous, violet in colour. And the differential diagnosis of this is like where you might have a coral graze, sometimes you'll get Staph aureus getting into the skin and causing an infection. Sometimes it's hard to distinguish between the two, but usually the treatment for Mycobacterium marinum also treats Staph aureus. Usually the treatment is, again, antibiotics, like with Mycobacterium ulcerans. And the antibiotics that work are trimethoprim or cotrimoxazole. That works. Tetracyclines work, although you don't give them to young children. Clarithromycin, again, fluoroquinolones like ciprofloxacin, norfloxacin, and rifampicin and isoniazid. If it's a deep infection, usually you need to treat for 3 months for Mycobacterium marinum, and usually it goes away. If it happens to be a secondary staph infection, then it'll be also treated with that combination of antibiotics. Wanted to touch on another type of granuloma now, but granulomas with cervical adenitis, and I guess we get used to a lot of cervical adenitis in children being called TB, and a lot of it is, but some of it is not due to Mycobacterium tuberculosis, but due to Mycobacterium avium intracellulare, and a typical form of TB, and some of it, of course, is due to Staph aureus. The maize complex, this Mycobacterium avium intracellulare, Scrofulaceum, and Kansassi, they're the Mycobacterium that can cause cervical adenitis or a cold abscess. And the distinguishing feature is that usually these children are previously quite well. They don't have the other features of Mycobacterium tuberculosis. They don't have pulmonary TB or systemic TB or more disseminated TB. It's usually just a firm, discrete, painless nodule that doesn't respond to normal antibiotics that you would give for Staph aureus, that keeps enlarging, and sometimes can get quite large, up to 6 centimeters, and becomes fluctuant. It's caseating, of course, and there is a skin discoloration over the caseating granulomatous nodule, and that can sometimes, the color can sometimes look rather purple too, not purpuric, but sort of violet in color, reddish violet, and the skin breaks down and discharges. These are a couple of children that had Mycobacterium scrofulaceum, and again, a well child, otherwise well child, who gets that sort of adenitis. It could be Staph aureus, of course, it could be Mycobacterium tuberculosis, or it could be Mycobacterium avium intracellulare. This adolescent also had a cold abscess that probably was Mycobacterium tuberculosis. This is another child with Mycobacterium scrofulaceum or maize complex, and you can see there's a sinus in the neck that is draining some pus, and typically you will see it on the CT scan. You can see in the supraclavicular region on the right hand side of this CT scan, you can see the lymph nodes, the adenitis. It's quite common. If you've got a child who's got you think might have Mycobacterium avium intracellulare complex and not TB, well, then first thing to do is exclude TB and screen for TB elsewhere. If you do a gene expert test on a fine needle aspirate, it will be negative if it's a maize complex, but sometimes the rifampicin resistance will be positive, as in it'll be rifampicin positive, as maize complex and TB shares the same gene for rifampicin resistance. So the RPOB gene, which is the gene that you're testing for when you do a gene expert test, looking for rifampicin resistance, that may be positive in maize complex as well as in TB. But the test overall will be negative for TB. The treatment, if you've got a child who's got non-tuberculous Mycobacterium, then the difference is that most of them get better with surgery. If it's an isolated mass, they can be excised and drained, and usually they get better. If it's not possible to distinguish between TB and non-tuberculous Mycobacterium, then they need chemotherapy. But if at all possible, in a well child who's got an isolated cervical adenitis, try to make that distinction between TB and non-tuberculous Mycobacterium. I'm going to discuss now parasitic infections of the skin and only touch on two. And the first one, parasitic infections can lead to a whole range of different abnormalities, but I'm going to just discuss two that are probably the most common. The first one is not the most common, but this is something that gives a very characteristic rash. And this is hookworm, and it's dog hookworm or dog and cat hookworm, and it's Ankylostoma brasilensis, and it leads to an infection that occurs usually in the lower limbs, and the nematode or the hookworm invades the skin and then migrates up the through the epidermis, and it can usually moves by only about a millimeter or so every day, but over time you can see the rash extending. Sometimes it vesiculates, like you can see in this picture. You can see a sort of vesicle occurring, and then that may break down. But this, what's the type of rash? It's called serpiginous because it seems to almost follow like a snaking appearance of like it's a worm that is snaking through the epidermis, just like one might expect a serpent. Cutaneous larva migrans. First, the larva penetrates the skin when a child is running around on ground, usually that is contaminated by dog feces that's infected with the eggs. Dogs are the main host of cutaneous larva migrans or Ankylostoma brasilensis. They excrete the eggs in their feces that then the eggs hatch, and the larvae that are then in the soil, and the larva penetrate through the hair follicles in the skin, the tiny little follicles in the skin or cracks in the skin, and then it doesn't become systemic. It only migrates through the local skin. So, but it's a rash that you can see relatively commonly, and you can diagnose it clinically. So it's good. It's always confined to the outer layer of the skin, the epidermis, as the larva can't penetrate through the membrane into the dermis. It's very, very itchy. So the rash is often secondarily affected by the child itching the lesion, usually in the feet, the toes, the hands, the knees, the buttocks, areas where there might be direct contact with the contaminated soil. The treatment is albendazole or ivermectin, single dose of albendazole or ivermectin, and usually within 2 days there's relief of the itching, and the lesions or the tracts, the serpiginous tracts, resolve within a week. So this is an important diagnosis to make. You can make a big difference to the way a child feels, because they go from being extremely itchy to having complete resolution once the worms are dead. And lastly, we could talk a lot about scabies, but I just want to include it in this discussion of infections that are common in tropical areas, because it's such a common infection. Due to the scabies mite, Sarcoptes scabii, and variant hominis. And that's important because there are animal scabies, but the scabies that infect humans, it's only human-to-human transmission. It was called by Aristotle lice of the flesh, and that's a very apt description, because it's one, they're both due to mites, and two, it's very, very itchy, as you know. The rash occurs 4 to 6 weeks after an infection, so after exposure, it's not straight away. And the rash occurs for two reasons. One, there's two aspects to it. One is the female mite mates with the male mite, and then the male dies, and the female burrows within the skin, in the stratum corneum of the skin, which is the keratinous layer of the dead skin, over the epidermis, or part of the epidermis, and there within the epidermis, the keratinous layer, the eggs are laid, So part of the rash is where you can see the female mite and the eggs and the inflammation surrounding that. And part of it is a generalized type 1 hypersensitivity reaction to antigens. And that usually is a bit delayed. The rash is a bit delayed. The generalized rash is a bit delayed. The distribution is always below the neck, so it's very rare to get scabies on the neck or the face. It's usually the hands, the wrists, the axillae, the thighs, the buttocks, the waist, soles of the feet, commonly, extremely itchy. The treatment is permethrin cream, 5% permethrin cream, or ivermectin is also effective against scabies as well, we know. And of course, launder the sheets and the towels and clothing that the child and the family have been receiving. Usually, you need more than one application of permethrin cream. Usually, one to start with, and then another one in a couple of days' time. Leave it on overnight and then wash it off the next day. That works in most cases. There are some scabies mites that are becoming resistant to permethrin now, and increasingly they're being reported. So then what you're left with is giving ivermectin, which is also very effective against scabies, extremely effective. So we've touched on some common tropical skin infections in children. We talked about the 5 common viruses, the 5 historical viruses: measles, rubella, parvovirus, roseola, HHV6, and hand, foot, and mouth disease. And we've talked about the 2 common bacteria, staph and strep. We've talked about some fungal infections, tinea versicolor. Briefly, we talked about aspergillus. And we talked about some mycobacterium infections, ulcerans, relatively common in moist environments, Mycobacterium marinum, especially in marine, saltwater, coral-related environments, and the maize complex causing cervical adenitis. And we talked about some parasitic infections, 2 in particular, cutaneous larva migrans and scabies. And I mentioned vitiligo. We haven't talked about zinc deficiency. That's for another day. But that's all I want to say today. But I think it's good to have a bit of an understanding of tropical skin infections and to be able to make distinctions between different sorts of common infections, so both common and uncommon. And think broadly about, could it be a virus or a bacteria or a fungus or a mycobacterium or a parasite? Could it be immune mediated, etc.? So it's good to think broadly, and it's good to have a good literacy, I think, of the terminology used in basic dermatology. So that's a run through of, I would say, dermatology for the paediatrician. I'm just going to stop sharing my screen, and I'm happy to answer any questions that you might have. I'm just going to stop the recording now, but if you've got any questions, please feel free to ask.